All right. We had some requests for some peds topics, so we're going to talk about peds trauma today. Also, some people asking a lot of questions about age of consent, which kind of mixes in well with talking about like some peds and peds trauma topics. So in Alabama, in October of last year, the governor signed the act that was passed by the Alabama legislature that changes the age of medical consent in the state of Alabama to the age of 16. Now, that means that you can give consent for care, right? So I can say, yeah, I want care, go ahead and take care of me. The problem is in Alabama, the age of majority which is the age that you can sign legal contracts, make legally binding decisions, all that kind of stuff is actually 19. It's actually here, it's 19. Nebraska is 19 and everywhere else is 18 except for one state where it's 21, which I think is Alaska, but don't quote me on that one. And so that obviously creates a little bit of a mismatch, right? So if I'm considered a legal adult capable of making legally binding decisions at 19, but I can consent to care at 16, that creates an issue because one would assume that a lack of giving consent is therefore a refusal of care, right? But you can't actually refuse care or sign a legally binding document like a liability release / refusal of care until you're actually 19. And that's where we get into a lot of the questions about how this works and how the legalities of this work. Basically, a minor can give consent for any care, mental health services, any sort of medical care, procedures like IV, whatever. All of that can happen at 16, and they don't necessarily have to have a parent to say, yeah, they want care. All right, they can get and seek out that medical care and receive that care at 16, regardless of who is there. Now, the parent can override that consent and refuse things for the kid until they are 19, though. All right, so we show up to like a 17-year-old in a car wreck and they say, hey, yeah, my arm's hurt, I want care. This gets really easy and it's basically done unless, suddenly mom shows up throwing some kind of temper tantrum, all right? And then they cannot, however, refuse that care at that same car wreck and sign a refusal until they're 19. So the way we typically get around this is we say, hey, mom, can you give me mom's cell phone number? Call mom. Hey, mom, is it okay for them to refuse? Yeah. And then kid signs the refusal. We witness it with like us and PD saying that it was like telephoned by mom and the kid signed. And then that constitutes a legally acceptable like refusal of care. All right, so that's sort of how we end up like getting around that for these kids, because obviously kids can drive at 16, right? And so there's a lot of 17-year-olds, 18-year-olds out there on the road by themselves or going places by themselves without mom and dad in tow to sort of sign that refusal. And that's generally how we work around that and sort of get around that and work around that in the field. So that's where things get a little bit interesting because if you can't get in touch with mom and dad, then we typically will involve medical control and involve a physician and say, hey, is it okay for this kid to refuse? We can't get a hold of parents. They will generally say, yeah, he's fine. He's in a car wreck. It's okay. And then what we will do is document that a physician said it was okay. The kid doesn't want care and is not giving consent for care and sign with a witness and do it that way. Now, that is a little slightly more of a gray area, but that is generally sort of how we have handled it. And there are actually guidelines for this. So the operational guidelines that the Office of EMS posted, these were updated after October of last year to reflect the new changes in the law. So each of the following individuals, you can see there, an individual is 16 years old. There are some exceptions to the 16 to that rule. Technically, if you were 15 and married in Alabama, which can actually happen under Alabama law, or even divorced, if you can marry, you can divorce, then you can actually give your own consent for care regardless. You can actually consent, you can sign, refuse care. You're essentially considered an emancipated minor at that point. Or if you have had a kid, you can consent for your own care and your child's care as well. So there are other ones, obviously pregnant, and then emancipated or not dependent. Let's see. And then obviously, again, nothing should prevent provision of healthcare services to a minor unless there is good faith belief that one of the following conditions: imminent threat, suspected abuse, neglect, or exploitation. So that is to say, if there is a serious concern that the kid is refusing care, but they're in imminent danger and they're being abused, and mom is saying no, that's when we involve medical control and police, and we can actually take custody of those kids and get them the care they need. That's just sort of the legal coverage for those sort of situations where it actually is in the best interests of the minor for safety reasons to still get them care despite that refusal. And then we're kind of what we just talked about, the age in 18, Alabama remains, age of majority remains 19, which is the age you can legally sign things and can be considered an adult. So parents still have access to the medical record. They can still override that refusal. Again, if we do think the care is in the best interest of the kid is consenting to care, but the parent is refusing, that's when we typically involve medical control. We can do things like get DHR involved. We can do some things to actually still get that care that they need for that kid. And we have done this a few times. There's, again, a couple situations where we've been involved. Like I personally have been involved as med control where like a kid was in an ATV accident, took a header into a tree. Mom is on the phone saying, no, don't transport him. And the kid is clearly very injured. And so there's been a few cases where we've done some things like that to sort of say, no, bring this kid here. Typically I tell people when these situations arise, err on the side of doing what is usually you think is the right thing, right? Like it is a lot more legally defensible if we end up in court one day to say, well, the kid who was bleeding out of his skull on the ground, I decided to take to an ER to get him care, than it is to turn around later on and go, well, I wasn't real sure what to do, so I just left him there, right? Like one of those is going to be clearly a lot easier to legally defend in court one day. So when in doubt, err on the side of getting kid medical care that you think they reasonably need is sort of the standard I give people. All right, I know that is very grayish, but does that sort of clear up some of the questions and make sense about consent versus refusal and age in Alabama? It's just a really weird way that Alabama law is written. Most states, the age of medical consent is also the age of medical refusal, and that is 16 because that's when kids drive and tend to be out more independently. So like in Virginia, where I used to live, you can both consent to and refuse care legally at 16. In Alabama, there is a mismatch between those numbers because of the way Alabama law is written regarding age of majority and creates that 16 to 19-year-old age gap where this gets very, very difficult to navigate sometimes and becomes a very gray area. In fact, thankfully, when they were raising the age to 16, they wanted to raise it to 19 to match the age of majority. And there was a big effort that was like, hey, you can't do that. Kids drive. They have to be able to accept medical care if they get in a car wreck. And thankfully, they listened to that because that would have created so many legal nightmares if we were standing there looking at kids and having to try and call parents to treat them on the side of I-65. So thankfully that worked out. But it's just sort of this weird mismatch in Alabama rules and laws that create that kind of 16 to 19 gap that create a really gray area. So does that answer sort of some of those questions a little bit? All right, cool. So moving on to peds trauma. So this kid, you would actually have to get parental consent technically, I guess, but whatever. 5-year-old female found a gun in the closet with their sibling, playing with the gun, accidentally discharged twice, single GSW to the head and to the thigh, initially responsive on arrival, now unresponsive as you're transporting. So this is not an uncommon case. This is like once a month in my ER, if that. There's our vitals. Heart rate 68, pressure's 140/90, respiration's 8, satin 80%, GCS is an 8T. Entrance wound to the left parietal scalp with an overlying hematoma and an entrance and exit over the left thigh with swelling and deformity of the thigh. So a lot of priorities on this kid, right? So there's some badness there. I don't think anybody loves those vitals. We'll talk a little bit more about them at the end. And obviously we have a head injury, significant head injury, as well as that thigh injury, which we all know kids, they have big chunky baby thighs. They can pack a lot of blood into those things. So a lot of concerning injuries there. Another one, 2-year-old female, improperly restraining the car seat. Vehicle rolled off the ditch in the interstate on the side of I-65 just past Lake Shore at a high rate of speed. thrown from the car seat in the vehicle and is entrapped. Initially a little fussy but alert. You has a prolonged extrication because of the way they're kind of lodged up into the car. And then after that, they're minimally responsive. Big old hematoma, facial swelling with facial injuries, bruising over the left chest, but no obvious crepitus, deformity over the left thigh, some scattered abrasions. So again, vitals aren't spectacular. They're honestly the same set of vitals, and that's kind of on purpose, but got a lot of injuries here, some bruising over the chest, which is a little concerning. And we got a lot of priorities in managing this kid, from airway to breathing to circulation. We're going to talk about some of the subtle differences about kids that make managing these kids a little bit of difference as far as our priorities, what we think about with those injuries, what might be underneath those injuries, and kind of how to handle those. Trauma overall is like, sort of very similar to adults, right? Blood goes round and round, air goes in and out, variations thereof need fixed, right? Stop the bleeding, make air go in and out. But there are some little things about kids that are a little different, about their anatomy, physiology, and sort of some of their management things that change some of those priorities a little bit. And that's really what we're going to focus on today. Those few subtle things that if you remember them can make sort of a little bit of difference in those kids that we do manage. So these are the top things that kill kids. Before 22, MVC. After 2022, firearms, and now the number one thing that caused the death of children in our country. But all those are traumatic ways to die. No matter which one of those lists you look at, those are essentially trauma patients. I guess maybe drowning is kind of not trauma-ish, but the rest of those are basically trauma, which is why peds trauma is such a big deal. It is the leading cause of death in our country for kids less than 1 year of age. And an unintentional injury accounts to 15 to 20,000 deaths annually, which is 30 to 50 kids per day. So essentially, like you got about 40 kids a day dying in our country of trauma. And 23 kids are killed by firearms every day in the US. So again, a big chunk of those, about half of those are killed by firearm incidents in our country. So we talk about this all the time. When we talk about trauma, you guys have seen this before. When we talk about any trauma topic, when we talk about head injuries and stuff like that, this is the trimodal distribution of death and trauma. And that's just to say there's three peaks where people die. There's the folks that die right away that we can't do anything about. The folks that die 1 to 4 weeks later, like complications, their injuries in the ICU, we can't do much about them. But there's these folks who, this second peak, these early deaths that die kind of early on, shortly after their injuries, and especially those folks who die in that first 30 to 90 minutes. Those are people that, like, when we get there, if we can do a good job, identify life threats, intervene, take good care of those folks, we can help them out and hopefully reduce that second peak a little bit. So that's really our method of trauma management. Is sort of designed around helping those folks because that's really our goal when we're in contact with them. We sort of talked about this, are kids just small adults? For the purposes of trauma, the answer is sort of. There are a few things that make them a little bit different. Their patterns of injury, some of their physiology. So we're going to talk about some of those things, which is really what we're going to focus on. Some of those things that, again, if you can just remember them, keep them in the back of your head as you take care of a kid, may make things a little better, a little easier, right? But they do have a smaller size, so they do get increased energy over surface area, right? If I get hit with a baseball bat in my abdomen, not a huge deal. I'm a pretty large person. I can absorb that pretty well. But if I'm this big, then that force gets transmitted over a much smaller surface area, creates a lot bigger injury pattern, right? Same thing is true for a gunshot wound, right? I get a 9mm wound to my upper gut, not a huge deal. I mean, I'm going to have some injuries, don't get me wrong. I ain't going to be happy about it. But that cavitation and that blast wave as that projectile passes through is going to do a little less damage than, say, in someone who's this tall, where that cavitation is going to pass out over a much larger area in them because they're smaller size, right? So creates a lot more significant injury. They also have less fat and soft tissues, so a lot of their underlying organs, their hollow solid organs and hollow viscous organs, they're not as well protected, right? So there's not a lot of padding for those kidneys, for that liver. So they do tend to get more organ injury as compared to adults. They do tend to fracture a little differently because their skeleton's a little less calcified and more flexible, but it also means, again, those underlying organs that are supposed to be protected by those bones that are nice and hard are not as well protected, right? Because those things are a little more soft and flexible. greater incidence of abdominal and chest wounds, and temp control becomes a much bigger deal. That higher surface area and lack of body fat leads to higher dissipation of heat, right? We think of what used to be the triangle of death in trauma, now is the diamond of death in trauma because they added a fourth side, and square of death doesn't sound cool enough. That one of those sides is hypothermia, right? So if those kids dissipate those heat and get cold, it's going to make things a lot worse. So we want to keep those kids warm. So when we talk about trauma management, we tend to talk about A, B, C, D, E, right? That trauma is divided up into kind of three parts. That primary survey where we systematically assess A, B, C, D, E, go through, identify those threats at each level, those life threats that we can immediately correct. And then kind of that secondary, more head to toe, looking for the more minor injuries. And then that third phase of sort of ongoing reevaluation and transport to definitive care, right? So we tend to focus a lot on that first part, which is A, B, C, D, E. Again, thinking of that second peak, that's where we identify those things that we can quickly correct and sort of help those patients do a little bit better. So we're going to look at the things that make kids just a hair bit different, and we're going to do it through the lens of that primary survey, that A, B, C, D, E. So most common cause of arrest and deaths in trauma is not establishing an airway in kids. We all know that kids' airways are just a little different, right? We've talked about this before when we've done PALS. They've got big heads, they got big tongues, they got big anterior airways, big floppy epiglottises, and all that means is that they are really prone to airway occlusion, right? So if I lay a kid flat on a cot or a spine board and just let them sit there, they will actually, that tongue will flop back, that head will push forward just a hair, and that airway will occlude with kind of on its own, right? And so doing things to protect that airway become really, really important. This is a picture of a kid's airway. You can see a 6-month-old, those big arytenoids, big floppy epiglottis, real narrow, especially even below the glottis there. The subglottic space is actually the narrowest part of their airway compared to adults. So we got to make sure we manage their airway, being cautious of their C-spine. If they need intubation, these are some of the reasons that we intubate kids. We obviously don't RSI folks here, but some of these folks will need an ET tube anyway. And we want to make sure we clear that airway, jaw thrusts to keep that airway open. And you really do have to use a lot of force to thrust up a kid's jaw, actually an adult too, anybody's jaw. It takes a lot more force than people realize to truly displace that jaw. Biggest mistake my residents and fellows make, they're sitting there, they're getting ready to intubate, they got the jaw thrust, they can't get the SATs the way they want them to tube them, and I just come up and like jam the person's jaw up with a lot more force, and then their SATs skyrocket. So it really does take a lot more force than you realize. If your hands aren't cramping and tired after a few minutes of doing it, you're probably not doing it right. And then we caution with oral or nasal airways, especially if we got a lot of facial palate injuries. We really don't use nasal airways in kids because they're high risk of head injuries, right? Kids are all big bobbleheads. They fall head first and have a lot of head injuries. If they got a basilar skull fracture, putting a nasal airway in can go poorly. So we usually don't use nasal airways really at all in kids for trauma. And we want to oxygenate and ventilate them. Typically, historically, we've used ET tubes as sort of the gold standard for airway management. Again, these are some things we've talked about before with PALS, but that paradigm is sort of changing now with the advent of the new high quality like supraglottic airways like the iGel, the AirTrack, some of these new products out there. That has sort of shifted now and a lot more focus on those because they're easy to use, they're reliable, and success rates for pre-hospital intubation, especially for trauma patients and kids, historically tend to be rather low. We're going to skip over this because this is some RSI stuff. But this is sort of important. We've talked about this with adults and minimizing secondary injury for head injury. Again, head injuries being really common. This is sort of why making sure we manage that airway so we can oxygenate and ventilate those patients gets really important. If folks in the early stage of resuscitation, if they suffer hypoxia around their head injury, you get a 150% increase in your mortality related to your head injury. So it is really important that we get pretty aggressive with managing that airway and making sure that it's protected. So again, if we're gonna making sure that those kids, that airway is protected, whether it's an oral airway, we know they don't have a palate injury, or just a really solid jaw thrust, or supraglottic airway, whatever it is, making sure that airway is protected, that it's open, and that they are getting oxygenated and ventilated. Looking at for when they're breathing, these are some signs of sort of respiratory distress in kids that we talk about: tachypnea, belly breathing retractions. Grunting, we sort of talked about when we talk about PALS, and kids who are really struggling to breathe, kind of on the far end of that spectrum of difficulty breathing, they'll start to grunt, which they can actually generate about 2 to 3 centimeters of water a peep by doing that. So it's a kid who's essentially put themselves on some CPAP. So grunting kids are sick kids that you need to take seriously. In kids, blunt chest wall and pulmonary trauma is pretty common. Again, those ribs are still really soft and flexible, right? So if you guys remember like old Looney Tunes cartoons where like Wile E. Coyote gets punched in the chest with the boxing glove and his like chest caves in and pops back out, kids will essentially do that. So they can have a lot of underlying injury in the chest, lungs, blunt cardiac injury, without necessarily having big broken out sections of ribs that you feel like in adults. Something we got to keep in mind. So our kid from the car wreck we talked about earlier, who had all that bruising over his chest wall with some trouble breathing, that's something to think about, right? Just because I don't feel a big broken out segment or a big flail segment in there doesn't mean I don't have a lot of underlying pulmonary or chest trauma. When they do get a flail chest, tends to occur with less ribs, only a couple. The good news is that vascular injury is uncommon, so everything in their mediastinum in their chest is not really as fixed. It can slosh around a little bit more. So you don't get a lot of vascular, like aortic root tears or big vascular injuries like you see with adults. But the side effect of that is when they do drop a lung and get a pneumo, because things are a little hypermobile, as that pressure builds, things will shift a little easier and create that obstructive shock that we see with tension pneumothoraces. So once they develop a pneumo, they are a little more prone to more quickly developing tension physiology and needing that decompressed. So sort of a double-edged sword on that one. So there's a big pneumo in a kid. If you got a chest x-ray before you put a needle or a tube in that, then something's actually probably gone wrong. And there's a big hemo in a kid. You can see the projectile fragment down there. Oop, wrong direction. All right, what are we doing here? I think my thing decided to die. All right, there we go. All right, so circulation, thinking about A, B, and C now. Kids, we want to check, make sure we pay attention to their heart rate. We talk about this with PALS, that kids have fewer mechanisms to compensate for shock, and so heart rate becomes really important in those kids. Pulses, perfusion, capillary refill is great in kids. Because those fewer mechanisms compensate for shock, one of the things kids do is they're really efficient shunters of blood, and capillary refill basically measures and tells me how much you're shunting blood, right? And how you're perfusing that periphery. Their color, being blue, is usually just generally bad. And then how they're acting, their mental status. Kids, once they start to get in shock, will start to get pretty sleepy pretty quickly. Tachycardia, again, early and most important vital sign change in kids. We'll talk more about that in a second. And then we talked about some of these other things related to circulation, pale extremities, delay cap refill, mental status. Kids are really good at compensating for blood loss. They have fewer mechanisms to compensate, but they're actually really good at it. One of the things they have that they can manipulate is their heart rate. And kids who all have young, healthy hearts, unlike adults, are actually really good at jacking up their heart rate, right? They can get up 170, 180, 190. It doesn't really bother them, to be honest. And so they can really jack up that heart rate in order to compensate for that blood loss and to keep blood moving and to keep it going efficiently. So kids can actually maintain a normal blood pressure up to and about 30 to 35% of their blood loss. So they can lose about a third of their blood and still maintain a normal blood pressure because they're so good at manipulating that heart rate. So that's why we say kids are really good, adept at compensating for blood loss. The problem is because they have fewer mechanisms, once they max out that heart rate, they sort of fall off the cliff. So that adage of kids do great until they don't, that's where it comes from. Because once they max out that heart rate and that mechanism, they don't really have anything to fall back on. And that's why kids don't really have a decompensated phase of shock. They do, but it's like, super brief. They basically move from compensated to kind of dead. And that's the reason. So hypotension is actually a really late sign of shock in kids. So these are hemodynamic changes due to hemorrhage in kids related to blood loss. So you've got the green lines, the heart rate, the black ones, the blood pressure, and the red ones are cardiac output. So what you can see is as they're losing blood, 15%, 25%, 30%, that heart rate is jacking up. And because they're so good at manipulating that heart rate with that healthy heart, they're actually able to maintain a very normal blood pressure, right? And then you get to about a little over 30%, that pressure finally starts to tank at around 45%, so close to half your blood loss, that heart rate starts to drop. That's your patient coding, right? So very brief window. Once their blood pressure goes down and they meet that traditional definition of shock, high heart rate, low blood pressure, you got a really, really brief time before they start to arrest, which is, again, kids don't really have a decompensated phase of shock. They just sort of move from compensated to dead or dying. And so what's important about this is if we can recognize these kids over on this side of the graph, right? If we pay attention to that heart rate, pay attention to that cap refill, pay attention to that mental status, those things we talked about when we assess for circulation, we find the kid over here and we can start resuscitating them before and keep them from ever getting to this point, right? So that's sort of the important point of shock in kids. Kids can maintain a normal blood pressure and still be pretty profoundly into shock, right? I mean, if I've lost a quarter of my blood volume, nobody's gonna argue I'm shocky, but kids will actually maintain a normal blood pressure. So pay attention to the heart rate, the cap refill, the mental status, look at those three cues. If they don't look good, if that heart rate's high, I don't care how good their pressure is, they're a trauma patient, they're in shock until proven otherwise, and treat them like it, all right? So we're gonna stop that bleeding as best we can on C, whether that's tourniquets, whatever. We're gonna stop the bleeding. Again, knowing that blood volume is sort of relative. If I lose 200 mLs of blood, not a big deal, but if I'm a 10-kilo kid, that's a quarter of my blood loss, right? So smaller volumes are a bigger deal. So we're gonna stop that bleeding, and we wanna make sure that we get some access. If we need to drill them and start an IO, that's fine. If they're shocky, they need it. We're gonna give them some fluids. We do prefer LR in trauma over normal saline. It's just a little more physiologically balanced. Doesn't have some of the side effects of the high chloride content that normal saline creates. And then 20 mLs per kilo is a bolus in a kid, and we can repeat that if we need to. If they're fluid unresponsive, again, because kids are prone to head and spinal injuries, we know that we may be dealing with some neuroshock. And at that point, we need to start thinking about like some epi, like a push dose epi or something to see if that'll help, right? Because those folks are gonna require pressor support because of their loss of sympathetic tone. D for disability, again, kids are prone to spinal and especially C-spine and head injuries. So we do a quick neuro assessment, check those pupils, look at the head, see if they're moving arms and legs, if they're old enough to, kind of follow commands, squeeze my finger, push down on my hands, make sure they can move everything. We're gonna get them in C-collars. We don't really backboard folks a ton anymore. But we want to make sure that we are really protecting that C-spine. There used to be kind of this notion out there that kids don't get C-spine injuries, and they do. They just get them differently than adults do. So they tend to not fracture. They actually tend to just sublux and dislocate. So their anterior and posterior spinal ligaments are actually really flexible, and their vertebrae are still kind of really wedge-shaped, like almost look like a slice of pizza. And so it's a kind of unstable structure that has like a giant bobblehead on top of it. And so what happens is kids don't fracture like adults do, like Christopher Reeves and that kind of stuff. They sublux. So what happens is that bobblehead moving back and forth on that unstable structure, one of those vertebrae slips out of place, and that's how they end up with spinal cord injury. They don't fracture, they dislocate. So they are really prone to it. So we gotta keep that in mind. It is really important to control C-spine in kids, even just as much as adults, whether it's babies, toddlers, whoever. So it is something we gotta think about. Again, talking about head injury, we touched on this earlier. Head injury is the leading cause of morbidity and mortality as far as injury type in kids. Again, big bobbleheads tend to go head first off things, right? So falls, MVAs, ATVs, bicycles, whatever, they tend to go head first and get head injuries. So no shock that that's a leading cause of injury and death in kids. Their brains are a little different. They contain a little more water. They are much more sensitive to decreased blood flow and decreased oxygen. So again, we talked about earlier, if they get hypoxic, you get 150% increase in your mortality. Also, if we let them get shocky, if we let that blood pressure start to drop, if we don't resuscitate them early on when they're tachycardic, and we start get them resuscitated in time. As that blood flow starts to diminish to the brain, kids will start to kill off brain cells a lot more quickly, and then start to worsen their secondary injury, which is our goal in preventing secondary injury when it comes to head injury in anybody, adults or kids. So again, really want to make sure that we avoid any hypoxia or hypotension in kids. Make sure we're finding them early on, like we talked about a second ago in shock in that C part, and start resuscitating them, and then make sure A and B are well taken care of. I put this in here to remind folks about Cushing's triad. Remember, we think of Cushing's triad as hypertension, bradycardia, at abnormal or diminished respiratory effort. When we see increases in intracranial pressure related to head injury. This is my reminder that it is the same for kids. You still get hypertension, bradycardia, and abnormal respirations, but the numbers are different, right? So, if I'm a trauma patient and I have a blood pressure of 140/90 and a heart rate of 70, breathing 10 times a minute, for most of our patients, we look at that and go, man, this is like the best possible vitals. This guy's in great shape. But if I am a 8-month-old who's supposed to have a heart rate of 140 and a pressure of 85/60, then that is high blood pressure and low heart rate for me, right? And I'm also supposed to be 25 a minute. So 10 or 12 is not bueno for me. So just keep that in mind as you're looking at those numbers, that those numbers become relative because they're different, right? So numbers we would normally look at and go, man, this is like the best vitals I've had on a patient in weeks. Suddenly become a lot more scary, right? And we want to make sure we aggressively treat those kids. If they do have Cushing's triad, they have some signs of increased intracranial pressure, we want to try and elevate the head of that bed about 30 degrees. We want to make sure we can give them some hypertonic saline or 3% saline. That'll decrease their intracranial pressure. It's 5 mLs per kilo up to 250 mLs. Jacking up their sodium creates an osmotic effect that brings down their intracranial pressure. We don't use mannitol here. You can briefly hyperventilate them for a minute or two. We don't want to hyperventilate people over the long term though. If we hyperventilate kids or adults long term in head injury, like the whole way to the hospital, by bottoming their CO2, it actually causes cerebral vasoconstriction, decreases blood flow. But as a short term, while we're pumping some 3%, elevating the head of the bed, temporizing measure to drop that ICP for a couple of minutes, it's acceptable. And the last thing, exposure, A, B, C, D, E, we want to make sure we look everywhere, right? Kids can hide injuries. For some reason, people who will like strip down a 20-year-old woman in the back of their ambulance and not think twice when it comes to like a 2-year-old suddenly get so modest for reasons I don't understand. Because kids love to be naked. If you find any 2-year-old, their favorite thing to do is rip off their clothes and diaper and run around the house. They are the last people who have any sort of modesty. So I've never understood the reason that like 30-year-old women come into the trauma bay completely undressed and like a 3-year-old little girl comes in like nobody's even like looked under a shirt at something. It's been like one of the greatest baffling things of my career, but kids love to be naked. Just help them out because they can hide some injury. So we got to take off their clothes, look them over head to toe. The biggest thing, remember, and we talked about this earlier, that high body surface area to mass ratio combined with their decreased fat stores, they will dissipate heat quickly. And remember that hypothermia is part of that diamond of death in trauma. So after we strip them down, we want to make sure we cover them up, keep them warm, because it can make things worse for us. So circling back to those cases that we started with, we got the 5-year-old female with the gun in the closet playing with her sibling, went off twice. So we look at those vitals. This is not a happy place, right? So again, if I told you this was a 50-year-old, you look at those vitals and go, man, this is probably the best vital she's had in like 30 years, right? But if I'm a 5-year-old, that is bradycardia, hypertension, and abnormal respirations, right? So what are we dealing with this gunshot wound to the head? We got Cushing's triad, we got an increased ICP, right? So we know we got to really aggressively manage this kid, especially because what's that number going to do to our mortality for that kid for their head injury, right? Jack that up. So we got to aggressively protect that airway, oxygenate, ventilate them. We want to start resuscitating them. We're probably going to give them when we get to D, a little 3% saline, right? Try and get that ICP down. We make sure we elevate the head of the bed a little bit on the cot. And then I'm also a little worried about this, right? Because This can bleed a lot, right? Fractured femur, big chunky kid thigh, pack a lot of blood in there. And if this number starts to drop, I'm in a real bad place, right? So we want to make sure we also really go ahead and just start resuscitating that kid and just assume they have some blood loss, right? So TBI, head injury, we literally talked about all this just now.